should be in the middle of the table. Vertex of their head should be level with the edge of the table. If you use a pillow with your patient, you want it to be one of those kind of flatter pillows. You don't want a big poofy pillow that induces a lot of flexion. If you do use that, then you want to at least account for that flexion when you set them up. She's in a pretty neutral position right here. In the angles that we want to look at for manipulation of C1-C2, we're going to want to look at 30 degrees of rotation, 46 degrees of side shift, side bend, and then 2 degrees of extension. That's how you set that up, those three angles. So 30, 46, 2. And those change slightly as you move to different areas of the cervical spine, but we're going to stick with C1 and C2. So talking through with me again, we get to 30, 46, and 2.
And it's 23 and 23, right?
Exactly. So that's where we're going next. Is you want to use a side shift, 23 degrees, and notice how she comes off midline when I do that, and then when I bring her back to side bend, we get 23 that way. That puts her vertex back on midline. So that's how we want to do that. What you don't want to do is side shift them, side bend them, and lose the side shift. You want to maintain that side shift as you do that. Okay? That's cranking a lot on this side. Let's move to this side. So when you're going to set them up, you want to use the palm of your hand placed on their parietal lobe. You don't want it on the occipital lobe. You won't get enough rotation out of that. You want it here above their ear. And then if you just rest their head in the palm of your hand, that induces 30 degrees of rotation. Makes it pretty easy. And then you want this proximal phalanx of the...
Whoa.
Yeah, I know.
Are you tripping up? I gotta leave the room.
You tripping?
Proximal phalanx of the second ray, right here, the anterolateral aspect. And that's going to go in contact with the transverse process of the upper section of the segment in question. In this case, C1, C2, so we want to be on the transverse process of C1. One of the easiest ways to find that is just place this on the mastoid, and then you come off the mastoid, and there you are, right on the transverse process of C1. So that's going to be your side shift hand. This hand gives you the side bend, this hand gives you side shift. You've already induced the rotation. Last little thing you need to do then is just use your fingers to induce a tiny bit of extension there. And there you're just looking for barriers. So I feel barriers right there. This is not an end range for her. End range is something like this and like that, okay? We want to be in mid-range, something like this. And barriers,
one more end range.
Of end range. This is end range rotation. And then if we want to start inducing some side bending and extension there, we're getting into some paraphysiological, we call it paraphysiological range. We don't want to be there. We want to be within physiological range. 30, 46, and 2 does that. So barriers on, off, on, off. And in the case of a PTA, maybe you're here and you're just then mobilizing here, right? You might even induce some of this here and you're mobilizing there, like that. You don't want to be aggravating to the patient, but you're playing with those grades 1, 2, 3, and 4. Right? So we feel her here on. I'm on the barriers. I'm slightly off. On, off, on, off. When you come slightly off and you go to thrust as a physical therapist, you're going to thrust through these barriers. So I feel the barriers here. That means when I end my thrust, we're going to probably end about here, her nose up just a little ways. So we're on, off, through.
That was a crack.
Pow.
We got 2 or 3 out of that, I think. So looking again at the other side. This is your primary force, but you don't want to be super pokey with this. I have been to demonstrate this, but really you want more distribution of your hand in contact with the occiput and the cheek and the neck. But your force, your primary force is still this here. So there, that should feel fairly comfortable for her, even though that's an aggravating little spot there.
Yeah, and you want it to be
on,
the
off,
finger, not the joint.
off. Yeah,
Yeah,
you want
the
a
phalanx,
broad
not the
part
joint.
here.
Yeah.
Yep.
Hey, if the pain is around C4-C5, why is it beneficial to do C1-C2?
Thank you so much for that
Yeah, that's
point.
good questions.
So you'll notice that with the cavitation that we got C1-C2. It's likely that we got C1 and C2, the target in question, but it's also likely that we affected joints below and maybe even above. And so if I hit C1 and C2, chances are good, if I do this correctly, I'll also get C3 and C4. That's one. Another is, if we want the long neurological explanation, is how pain inputs are relayed to the cortex through the trigeminal cervical nucleus. And we can talk more about that if you want to. Yeah. On, off, through. Some baby pops there, but we still got some. So.
I'm gonna do your neck. Can I?
Yeah.
Cool.
So, real quick, a couple of things that I did not cover that I should have covered. Before you manipulate someone, you need to know three things. One is what their vital signs look like, because that's going to give you an indication if they should not be manipulated. Two is their history of trauma, if they've been in some kind of accident. Then you need to follow the Canadian C-spine rules and see if they need the x-rays first. And then three is any signs of stroke, particularly the 5Ds, 3 Ns, and 1A. If they're presenting with any of those, that person doesn't get manipulation. But quite honestly, if anybody has a problem with vital signs and history of trauma and 5Ds, 3 Ns, 1A, they shouldn't get anything physical therapy or PTA or massage. So make sure that we screen for those things before we do any treatments, but particularly manipulation. Okay. Questions on that?
Sometimes I know that people who are hypermobile should still receive manipulations, though I do have more struggles in the neck with people who are.
So that's where searching for those barriers is going to be important, and they probably will be more than 30 degrees of rotation. They probably will be more than 46 to 46 as you try to find those barriers.
Sure. Okay, cool.
Yeah. And in the case of a hypermobile person, we're not trying to increase their range of motion. We're just trying to improve their quality of movement. Should we try it?